Navatika Mohanty and Dr. Gitumuni Sharma for today's our eyesight meeting. Let me introduce first Dr. Navatika Mohanty. Uh, Dr. Navatika Mohanty presently she is working at Sankara Eye Hospital, Berhampur, Orissa. She did his as a vitreoretinal surgeon. She did his vitreoretina surgery training from Trilution Netrala, Sambalpur. She has extensive experience in the diagnosis and management of retinal disorder, diabetic retinopathy, uveitis and vascular occlusion, and vitreoretinal surgery. Her academic interests include teleophthalmology, retinal imaging, and research in diabetic retinopathy screening. She has presented papers and participated as a speaker and panelist at various state and national conferences, including OSOCON, AIOC, MTC, and TOSI session. She has she has multiple peer-reviewed publication in index journal, and she is actively involved in academic and research activities related to ophthalmology and vitreoretinal disease. Welcome, Dr. Navatika Mohanty,
Thank
for
you. Thank you.
today's our session. And let me introduce our second speaker, Dr. Gitumani Sharma. Gitumani, ma'am, welcome to you to this session, to this our eyesight meeting. Dr. Gitumani Sharma, working as a consultant UVA ROP and vitreoretinal surgeon at ASG Hospital, Paltan Bazar, Guwahati. She's also a cataract surgeon, and she's having more than 20 years of experience in ophthalmology segment. She did his MBBS from Assam Medical College, Dibrugarh in 1991 and had completed post-graduation in ophthalmology from Sri Sankara Deva Netrala, Guwahati, and from where she had also completed 2 years of residency and thereafter fellowship in general ophthalmology and cataract. Thereafter, she had completed fellowship in clinical research and in surgical vitreoretina from Retina Institute of Karnataka under Rajiv Gandhi University of Health Science and Health in Bangalore. She has experience in diagnosis and treating all eye conditions. She is a regular speaker in many national and international ophthalmological society conference where she also is a life member and had presented more than 70 papers till recently, of which is 10 were gold medal winning papers. And she has 27 research publications being published in national and international index and non-index journal. She's also an MBA. She did his MBA in the hospital and healthcare management. She's also an NABH assessor and was a quality coordinator. Welcome, Dr. Gitumani Sharma, to today's our eyesight meeting.
Thank you. Thank you so much. Yes.
And so our first topic is evaluating anti-VEGF drugs, molecular characteristics, and their impact on treatment success. The speaker is Dr. Navatika Mohanty. So I'll hand, please welcome Dr. Navatika Mohanty, ma'am, and present your today's presentation. Thank you, ma'am.
Thank you, Dhrubajit ji.
Yes,
Thank you for your kind introduction.
yes, yes.
I'll share my slides now.
Yeah.
Are my slides visible?
Yes, ma'am, your side is visible, ma'am.
Okay, okay. So, good evening, everyone. At the outset, I would like to thank Bayer Pharmaceuticals for giving me this opportunity. Today, I will be discussing the topic evaluating anti-VEGF drugs, molecular characteristics, and their impact on treatment success. So, over the next 15 minutes, we will explore how molecular properties such as binding affinity, potency, half-life, and target profile influences anti-VEGF therapy in retinal diseases. So, why this topic matters? Anti-VEGF therapy has revolutionized retinal practice and remains the standard of care for most of the diseases like diabetic macular edema and neovascular AMD. However, multiple available agents are there. So, which agent to choose? We truly maximizing the outcomes by choosing the proper agent? So, this presentation examines whether molecular differences between anti-VEGF agents translates actually into clinical benefits. So, to understand these therapies, we first need to revise the VEGF pathway. in diseases like diabetes, there is impaired hypoxia and leads to secretion of VEGF, leads to activation of VEGFR1 and VEGFR2, and placental growth factor leads to secretion of inflammatory cytokines. And all these agents together lead to angiogenesis and neovascularization, leading to vascular vessel leakage and edema. So aflibercept, why aflibercept is different? Because it is structurally different. It is made up of a combination protein of VEGFR1, VEGFR2, and FC portion of IgG1. The VEGFR2, it binds VEGF-A, but VEGFR1, it binds VEGF-A, B, and additionally placental growth factor. So due to having multiple targets, it leads to more effective suppression of VEGF. Now, several molecular factors determine how a drug interacts in the body, such as binding affinity, potency, elimination half-life, clinical targets, and molar dose. Coming first to binding affinity. Now, binding affinity is measured using the equilibrium dissociation constant, or KD. A lower KD value indicates stronger binding. Among currently available agents, aflibercept demonstrated the highest VEGF binding affinity, followed by brolucizumab, and then ranibizumab. Faricimab VEGF affinity appears comparable to ranibizumab in available studies. Aflibercept showed statistically stronger VEGF binding in head-to-head in vitro studies. Coming to potency, potency is measured by IC50, meaning that the concentration required to inhibit 50% of biological activity. Again, lower values indicate better potency. Aflibercept demonstrated significantly greater potency compared with brolucizumab and ranibizumab in vitro. So this suggests stronger VEGF suppression even at lower concentrations. Coming to half-life and durability, another important characteristic is the half-life, one of the most important characteristics rather. Aflibercept has an estimated intravitreal half-life of approximately 9 to 11 days. This is longer than brolucizumab and somewhat longer than ranibizumab and faricimab. So a longer half-life may contribute to sustained VEGF suppression and durability in clinical practice. So binding target is a very important thing. So the more number of targets are bound, it indicates better suppression of VEGF. Now, existing anti-VEGF agents like brolucizumab and ranibizumab, they have single target binding like VEGF-A. Faricimab has dual targets, that is VEGF-A and angiopoietin-2. But aflibercept, it has multi-target binding property, which binds VEGF-A, placental growth factor, VEGF-B, and additionally galectin-1 also. So, aflibercept significantly decreased intraocular VEGF and PIGF levels from baseline to month 2 in patients in DME as per various studies. Now, in patients in DME, it has been seen that the VEGF levels increase up to 61 folds, whereas PGF level increases up to 19 folds. So, additional binding of PGF is a very important factor, which is seen with aflibercept. So could targeting additional pathways such as angiopoietin-2 beyond the VEGFR pathway further improve efficacy outcomes? Now let's see. So these factors like VEGF-A, placental growth factor, angiopoietin-1, angiopoietin-2, they play a critical role in the development of edema, retinal vascular permeability, inflammation, neovascularization, and vessel stabilization. So is the angiopoietin-2 or Tie2 pathway relevant target for the treatment of exudative retinal disease? Let's see. So during angiogenesis, angiopoietin-2 is upregulated and competitively binds Tie2. In high VEGF states, angiopoietin-2's antagonistic activity may promote destabilization of blood vessels. But in low VEGF states induced by anti-VEGF treatment, angiopoietin-2 has very less relevance. So basically what I want to say is that anti-VEGF agents itself decreases the angiopoietin-2 levels. So only targeting VEGF is enough, and in that aflibercept is the most potent binder of VEGF compared with other available agents. Studies like Ruby and Onyx, which have been conducted by Bayer and Regeneron, they investigated the angiopoietin-2 pathway in combination with aflibercept. Faricimab has weaker binding affinity for angiopoietin-2 than for Tie2 receptor, whereas nesvacumab has a stronger binding affinity for angiopoietin-2. In these studies, what it was done, aflibercept was combined with nesvacumab and given in cases of DME and neovascular AMD. And it was seen that combination of nesvacumab and aflibercept provided no additional functional benefits as compared to aflibercept monotherapy. Now, other studies like Yosemite, Rhine, Tenaya, Lucerne. So these are unbalanced study designs which favored faricimab and the additional angiopoietin-2 targeting with faricimab, but they did not confer any additional clinical benefit over aflibercept. Now, this is another clinical study which is named AVNU, which was done on faricimab and razumab. So it was seen that anti-VEGF monotherapy neutralizes angiopoietin-2 levels to levels compared to that achieved when directly targeting angiopoietin-2. So basically what it was seen that targeting anti-VEGF2 alone is enough because that itself reduces angiopoietin-2 levels. So additional targeting of angiopoietin-2 was not necessary. So anti-VEGF prevents VEGF-driven angiopoietin-2 production, and this effect is greater and persists longer with aflibercept versus brolucizumab and ranibizumab. So the results of this study support the hypothesis that angiopoietin-2 may be expressed secondary to primary insults to retinal vasculature by VEGF. So direct inhibition of VEGF is enough. Aflibercept delivers comprehensive and highly durable targeting where it matters. Like we saw multiple properties such as binding affinity, the estimated human half-life in days, then equivalent molar dose, number of targets, potency. In all these aspects, aflibercept happens to be superior to its contemporary anti-VEGF agents which are existing in the market. Diabetic macular edema treatment guideline, as suggested by the AIOS-DR task force and VRSI, suggested that intravitreal injection of anti-VEGF agents are the first line of treatment in treatment-naive central involving diabetic macular edema. Laser treatment has been shown to be an effective treatment, but that was earlier. Now, anti-VEGF happens to be the main line of treatment. Real-world studies are equally important. So data from Moorfields and other centers demonstrated that aflibercept achieved sustained visual gains, meaningful durability, and reduced injection burden over time. Now, these outcomes were seen across neovascular AMD, PCV, and diabetic macular edema. So importantly, proactive treat and extend regimens maintain vision gains over several years. So to summarize, the major take-home points are: first, aflibercept demonstrates high binding affinity, strong potency, and durable VEGF suppression. Second, it targets VEGF-A, VEGF-B, and PIGF, allowing broader inhibition of the VEGF pathway. Third, current evidence suggests that additional pathway targeting, such as angiopoietin-2 inhibition, has not yet translated into superior visual outcomes over optimized anti-VEGF therapy. And finally, real-world data continue to support aflibercept as a highly effective and durable therapy across retinal vascular diseases. So to conclude, with aflibercept already targeting key ligands within the VEGF pathway, there may be limited room for further improvement in functional outcomes using alternative pathway inhibition alone. Thank you.
Thank you, Navatika ma'am, for your
Questions are welcome.
And you explained very well about the benefit of aflibercept. So if there is any question, the audience can ask to Dr. Navatika ma'am, or you can ask after finish the second talk also. So if there is no question, then I would like to welcome Dr. Gitumani Sharma for the second talk. Ma'am, presentation is diabetic macular edema from understanding to treatment. Please, Gitumani ma'am, please start your session. Ma'am, you are mute, ma'am. Please unmute the.
Is my screen visible?
Your screen is visible, ma'am. Please make it
Okay.
full screen, ma'am.
Full screen. I have made it full screen.
Okay. Now it's okay, ma'am.
Yeah. So I shall be going about diabetic macular edema from understanding to treatment. These are the disclaimers. It is expected, as we all know, that the global burden of diabetes will continue to rise in the Africa, Middle East, and North Africa and Southeast Asia to maximum by the year 2045, as is been shown in the slide. Already, Southeast Asia continues to bear many millions of diabetes at maximum. Now, what is diabetic macular edema? It is the presence of excess of fluid in the macular area of the retina and can result in loss of visual function. It occurs when the blood vessels in the retina leak fluid and proteins into the macula, causing the macula to swell up, which in turn affects the visual function. Now, VEGF-A has already been described in the previous slides by Dr. Navantika, that it plays a key role in the pathophysiology of diabetic macular edema. VEGF-A increases vascular permeability and disrupts the blood retinal barrier in diabetic macular edema, which is the leading cause of moderate to severe vision loss in patients with diabetes and a leading cause of blindness in working age populations, specifically in most developed countries. Diabetic macular edema can affect people with both type 1 diabetes and type 2 diabetes. Now, the quality of life reduces drastically because it affects the working age population. If left untreated, it can lead to severe visual impairment, and it can occur in any individuals in any stage of diabetic retinopathy, and badly controlled and left untreated can lead to severe visual impairment up to blindness. Now, the treatment of diabetic macular edema has evolved in these years since 1985 to 2011 to 2012, when laser was the gold standard in 1985 to 2011 in ETDRS and FAME studies of steroids in diabetic macular edema. But by 2023, since 2011 onwards, now anti-VEGF is the new gold standard, as in the Restore, Rise and Tide, Vivid, and Vista studies. Now, let's know what are the factors which drive the key mechanism behind the pathogenesis of diabetic macular edema. So, VEGF-A and the PLGF acts via the VEGF receptors to promote vascular leakage, edema, and inflammation and neovascularization. VEGF-A acts via the two receptors 1 and 2, and that placental growth factor acts both directly via the VEGF receptor 1 and indirectly via the VEGF receptor 2 by displacing VEGF-A from VEGF receptor 1. The heterodimers of VEGF-A and PLGF can induce and activate receptor 1 and 2 and bind to VEGF receptor 1. Now, excessive activation of the VEGF receptor 1 and VEGF receptor 2 can result in increased vascular leakage and edema and inflammation and pathological neovascularization, and which in turn are the key mechanisms that drive the pathogenesis and progression of diabetic macular edema. The roadmap is been shown in this chart, where first what happens is hypoxia due to impaired retinal blood flow, and there is inflammation, vascular permeability, and neovascularization. Ultimately, the cycle continues of vessel occlusion, vessel leakage, and edema due to breakdown of the blood retinal barrier. Now, aflibercept, till now globally available, is the only anti-VEGF agent that targets multiple mediators of retinal diseases. So now if we summarize this slide, then what happens is VEGF A and VEGF B, something is wrong here. So aflibercept will have VEGF A, VEGF B, and PIGF, which is been blocked by the aflibercept, which are the multiple mediators of the retinal diseases. This is in summary now. Till now we know about this. Now there are several sources of evidence support anti-VEGF choice for patients in the RCTs, real world evidence, network, meta-analysis, international guidelines, mode of action, and patient's own experience, that is patient's cases are there. So it is important to provide timely and effective treatment for all patients with DME and ensure that vision gains are maintained in the long term. Now, we have two major studies which are VIVID and VISTA. These are phase 3 trials which show the impact of aflibercept in diabetic macular edema. In VIVID and VISTA, clinically meaningful vision gains were achieved in patients who received early intensive treatment with aflibercept. Here in the chart, in both the studies, we do see that the lower gray color line is of laser, and the upper yellow and the blue color lines are of this 2 milligram aflibercept given in the patients. Now, in these trials, there is clinically meaningful vision gains were achieved in patients who had received early intensive treatment with aflibercept. Vision gains were observed as early as with the first aflibercept injection. Patient received more than 8 injections through first year and maintained vision gains achieved during the initial loading phase. Across all these 3 studies, patients treated with aflibercept gained on an average more than 10 letters. At the 52 weeks of primary endpoints, aflibercept demonstrated superiority to laser in both the VIVID and VISTA studies. Now again, delaying aflibercept treatment lead to poor visual outcome. Here we see that after the 52 weeks of primary endpoint is finished, then even in the laser group, both the studies, the vision started, when the vision started dropping down, patients were given injection aflibercept, and again there were improvement to some extent. But when they were injected all throughout as PRN doses in both the yellow and the blue line, the visual gain is maintained. So patients in the laser group were eligible to receive aflibercept PRN from 100 week if they met predefined vision loss and OCT criteria. 48% and 46% of laser control eyes received aflibercept PRN from week 100 to week 148 in both the studies respectively. Now, what do the meta-analysis and expert international guidelines recommend for the treatment of diabetic macular edema? Let's see. This is a Cochrane meta-analysis which reviewed evidence from different major studies investigating the efficacy of anti-VEGF agents in diabetic macular edema, which concluded that at 1 year, all efficacy outcomes significantly favored aflibercept over ranibizumab and bevacizumab, and patients were approximately 30% more likely to gain more than 3 lines with aflibercept than with ranibizumab or bevacizumab at first year. Anti-VEGF agent did not differ regarding the adverse events at year first and year 2 of follow-up, and the other meta-analysis suggests aflibercept is the most favorable treatment for patients with diabetic macular edema, and consistently with aflibercept showed evidence of superiority when compared with ranibizumab PRN dose for mean change in BCVA gain of more than or equal to 15 ETDRS letters and loss of more than or equal to 10 ETDRS letters from baseline to month 12. And if we compare the mean change in BCVA from baseline to month 12 and mean change in the central macular thickness from baseline to month 12, aflibercept is fairly better in comparison to ranibizumab and laser, ranibizumab alone, dexamethasone implant and laser alone. And if we come to the international guidelines and recommendation, it suggests aflibercept should be the drug of choice where patients' BCVA is less than 20/40 or worse. If we consider the EURETINA guidelines of 2017, then they say that aflibercept is the drug of choice in diabetic macular edema eyes with baseline BCVA below 20/40 or worse, as it shows superiority to bevacizumab over 2 years and over ranibizumab in the first year of treatment. Again, Asian recommendations in 2018 says that in patients with worse visual acuity than 612, aflibercept may result in more rapid visual improvement than ranibizumab, 0.3 milligram over 1 year, although this difference was not statistically significant in year 2 of the DRCR.net Protocol T study. Again, Canada guidelines of 2018 says that superiority of aflibercept was noted in the group of participants with worse baseline visual acuity. This superiority of aflibercept at year 2 with gains of 18.1 letters in aflibercept, 13.3 letters in bevacizumab, and 16.1 letters in ranibizumab groups at 2 years. Again, German Ophthalmological Society guidelines of 2019 says there is evidence for a possible difference in drug efficacy in patients with diabetic macular edema to the disadvantage of bevacizumab at a visual acuity of less than or equal to 20/50. So can these guidelines and meta-analysis inform anti-VEGF treatment in clinical practice? Data from Moorfields Eye Hospital and FRB registry assess the efficacy of aflibercept in patients in clinical practice. They say that poor baseline visual acuity is commonplace in up to 2/3 of patients in clinical practice. And the adjusted mean visual acuity gain from baseline to 12th month in eyes with initial vision of less than 20/40 or worse was significantly higher in eyes receiving aflibercept than in those receiving ranibizumab with a similar number of injections. Now, the VIVIM treat and extend with aflibercept initiated in year first can provide clinically meaningful visual outcome over 2 years. Even this study, Hirano et al. Says that the majority of patients with diabetic macular edema achieve 16-week treatment intervals with an individualized treat and extend regimen with aflibercept initiated at year first. Again, JED study shows that aflibercept treat and extend initiated after 5 monthly loading doses provided significant visual acuity improvement in patients with diabetic macular edema. So to summarize, aflibercept can have meaningful visual gain, and the RWE highlights the effectiveness of aflibercept in the clinic where patients regularly present with poor baseline visual acuity, and patients with visual impairment due to diabetic macular edema, particularly those with baseline visual acuity less than 20/40 or worse, can achieve a meaningful visual gains compared to other anti-VEGF agents in the real-world clinical practice. Thank you all for your patience hearing, and I must thank Bayer Pharmaceuticals for giving me this opportunity.
Thank you, ma'am. Thank you once again for your wonderful presentation. You will explain all the benefits of aflibercept, and you will explain the studies of the VIVID and VISTA and Morphill and Iranoid, all the studies. Thank you once again, Gitumoni ma'am, Navatika ma'am. Now floor is open. So if anyone having any questions, so you can ask to our both the speaker. They are well expert in this profession, so they can definitely they can help you out for your queries and questions. Hello. If there is no question, so we can close our session. Sanjit,
Yes, yes.
if there is no question, so
Yes, we can. Thank you. Thank you, ma'am.
thank you, ma'am.
I have a question for ma'am.
Okay.
Yes.
Ma'am, how do you like to go about idea in with respect to DME and the neovascular AMD? What is the regimen that you prefer?
Regimen means you are asking about the loading doses, right?
Yes, yes.
Yes. Monthly 3. I would like to go for monthly 3 loading doses, and then
Yes.
like as per the requirement, treat and extend. And I have seen that mostly the cases like they respond very good with the 3 injections. Loading
In those
doses are
with
they
the
are
loading
more
dose
than
is
enough.
enough. Yeah. Yes, I
Yes.
agree.
The drying effect is very good with the injections.
Yes, I agree.
3
I
are more
agree.
than enough. Yes, right?
And if, in your experience, after how long have you seen that they need a repeat injection, as in
After the
PRN
3?
basis or treated? Yes.
Yeah. Yes, very few of them who will require it at again like after 2 months, if I 2 or 3 months, that is 8 to
Okay.
12 weeks, they will need the other one. In PC, like in AMD, they will require, but diabetic macular edema, I have seen 3 are more than enough. Why? It's because uh, it's more than enough when they're systemically controlled, like their system has to
Correct.
be
That
good,
is a
like
very
all the
important point.
hypertension and lipid profile, anemic and everything, if it is controlled, then they do fairly well. And wherever
Yes.
lasers are required, if you give like PDR cases, severe and PDR, and if it is a
Hmm.
well laser, they don't require keep, like I don't have many cases who are repeatedly taking injections. I don't have many, 1 or 2 maybe I'm having PRN, but others are okay
Hmm.
with the drug.
And is there any difference between CNVM and PCV approach that you have seen, like how they are responding?
Yes, PCV response very good.
Yes, that's what I have noticed, that with PCV it is excellent.
Excellent, yes. All like even with one injection, they do very good. So they themselves come. Like even I have 1 or 2 cases who are by themselves and taking the injections.
Oh, amazing, amazing, ma'am. Excellent. I totally agree. I totally agree with that. Yes.
Yes.
Yeah,
That's it
Dr.
from my
Gitu,
side. Thank you, ma'am.
Dr. Gitu, how do you prescribe in
Yes, sir.
nephropathy cases? Any special precaution you take?
Yes. I don't take any kind of precautions because diabetic macular edema, I would like to go for like steroid in nephropathy cases, or like anti-VEGF and steroid together. That will that will have good outcome instead of only giving anti-VEGF. I don't repeat anti-VEGF unless my nephrologist says that you can give like that. It will depend on how what my nephrologist tell to me whether to continue with the anti-VEGF. This is about DME, but in case of PCV, I have to inject. I tell my nephrologist, you take care of it, and I have to give. I will see if one injection, like the patient is good, then I will treat and extend better. I would like to treat and extend if nephropathy and PCV are coming together.
Actually, in nephropathy cases, there is no any common consensus. So among the nephrologists also there is variation in
Yes,
opinion.
yes.
Some nephrologists strictly say that the anti-VEGF should
Ah,
not be given, and some nephrologists they are very much reluctant in the ophthalmic anti-VEGF will not affect. So
yes,
actually, so it is difficult to say how much of an intraocular anti-VEGF will actually reach the systemic circulation to affect the kidney function.
yes, yeah, yes.
But still, we will have
But
to. Yeah.
like
Better be in the safer side to take an opinion from the nephrologist.
Yes, I do that. I do that.
If I may
And for,
add, sometimes, sorry, sir, you were saying something,
no,
sir.
it's okay. Go ahead, please.
Sometimes I have seen when nephropathy cases, particularly those on dialysis, I prefer going for a heparin-free dialysis prior to giving the injection.
Heparin-free dialysis. Why?
Uh, I just they say before dialysis, and it the bleeding, one, it controls the bleeding. Second is just after dialysis the parameters are relatively lower, so we prefer that. The renal parameters are on the safer side.
Thanks for the input. Thanks.
Yeah, like next day of the, I ask the patient for any kind of intervention, my intervention, I ask them go for the dialysis first, then come to me the second day of dialysis. Yes, but heparin free. Thanks for the input. It's good.
Yes. Yes.
Thank you, Manavjyoti Burman, sir, for your questions and explaining well regarding the nephropathy cases. Thank you, Nabatika ma'am.
Thank you, Dhruva.
Thank you, Gitemuni ma'am. You will explain all that.
Thank you.
Thank you.
So
Thank
if
you.
there is no question, so we can close today's session.
Good night,
Sanjay?
everybody.
Good night. Good night, ma'am.
Thank
Good
you.
night,
Good night,
everyone.
ma'am. Good night.
Good night. Thank you so
Good night,
much.
sir. Manav sir. Good
Good
night,
night.
sir. Thank you. Thank you, everyone.